Okay, so let's move to the last question, which is the selection of the right antibiotic. So this is the guideline in which for the first time they remove clindamycin. We don't give clindamycin for antibiotic prophylaxis anymore. So it means the first choice would be amoxicillin. Make sure you know the dosage for adult and for the kids. Always question. And when they give you the dosage, when they give you a question for the kids, you simply multiply the patient weight by this number, meaning that if the patient weight is 30, you multiply 30 by 50, it makes it 1,500. And keep in mind that you should never go beyond the adult dosage. So it means if you have a heavy child is 45 kilogram, so 45 multiplied by 50 is going to be beyond 2 grams. It's still, you give 2 grams. You never go beyond adult dosage. Okay? So all the numbers are important in this list. I'm not going to go over the numbers one by one. Make sure you memorize them. Super duper important table. Okay? Very highly likely that you get the question from this table. So this chapter in general is super important, okay? Patients who cannot take the drug orally, cefazolin and ceftriaxone, allergic to penicillin. So pay attention to this one. As long as the allergy is delayed, so it's type 4 delayed, you can give cephalexin. If allergy type is not mentioned, or it is immediate, then you don't give cephalexin because of cross-allergenicity. Okay? Azithromycin, clarithromycin, doxycycline. Okay? Azithromycin, clarithromycin, and doxycycline. Those are the drugs that if you don't know the type of allergy or the allergy is immediate type, you go with, and all of them are acceptable. So doxycycline is new. We didn't have it before. So there was a typo in the American Heart Association guideline. They put this 4.4 by mistake, but this is the right number. So if the child is lighter than 45 kilogram, this is the right dosage. If the child is heavier than 45 kilogram, 100 milligrams. So because it's going to be beyond adult dosage. And lastly, patient who is allergic to penicillin, unable to take oral medication, cefazolin, ceftriaxone. Okay. Cephalexin. What did you say about cephalexin? I said, if the patient has delayed allergic reaction to penicillin, we can give cephalexin. Okay. If you do not know the type of allergy, the question doesn't mention the type, or you know the type of allergy, but the type of allergy is immediate or anaphylactic, then you should avoid cephalexin. Okay. I didn't see anywhere put antibiotic prophylaxis for retraction cord. I can double check that, but as far as I remember, it didn't mention anywhere. But I'll double check. Okay, so this is also another important point about antibiotic prophylaxis, and that is if the patient right now is on antibiotic, so within the past 9 to 14 days. So let's say patient is taking antibiotic for an ear infection or for an abscess, and the patient comes to you and wants to do the tooth extraction, and patient has the history of infective endocarditis 2 years ago, meaning the patient is a candidate for antibiotic prophylaxis. Okay? So in this situation, if the patient is taking amoxicillin for his infection, okay? So as long as the patient is on amoxicillin for the past 9 to 14 days, you should not give an antibiotic from the same family. So amoxicillin is from the family of aminopenicillins. So you should give antibiotic from another family, means you should give clarithromycin or the doxycycline. Okay? So as long as the patient is on an antibiotic for the past 9 to 14 days, and this antibiotic is going to be the same as what you want to give the patient for antibiotic prophylaxis, you should avoid giving the same antibiotic. Okay? So give the antibiotic from a different class. For example, if the patient is already taking amoxicillin, give the patient doxycycline, azithromycin, clarithromycin. There is another approach to wait for 10 days and then like give the same antibiotic, but what's the point? Just give antibiotic from another class, okay? Take a look at this question from your notes. A 68-year-old patient, history of MI 4 months ago. So patient has a history of MI 4 months ago. And 2 coronary stents. These 2 coronary stents, like placed, I don't know. Patient wants to do a scaling route planning. What is the most appropriate course of action? So it's kind of like a question mix of patient management and antibiotic prophylaxis. Okay. So what do you think is the best answer? The first thing that you have to do in questions like this is to determine the type of procedure. So this procedure is considered as an elective treatment, okay? It's not an emergency, it's elective. So it means if the patient has a serious medical situation, we should delay the procedure, okay? MI happened 4 months ago. How long should we wait after MI? 30 days. So it's well beyond that. Okay? So that's for the MI. So it means you are allowed to do elective procedure. This is wrong. This is wrong too. So my answer is between C and D. So let's talk about coronary artery stent. Coronary artery stent in general does not need antibiotic prophylaxis. And this patient has just coronary artery stent. So option C is also wrong. So we are only left with option D. Yes, a patient who has a history of MI requires anxiety reduction protocol. So that makes D the right answer. Okay. So patient, because of history of MI, requires antibiotic, requires anxiety reduction protocol. Coronary stent does not require antibiotic prophylaxis in general, unless you are doing drainage. So that's the only exception. If you're doing drainage for an infected device, then you need to consider antibiotic prophylaxis. What about patients who have immunocompromised situation or compromised host defense? So the best example of this situation would be uncontrolled diabetes. So for uncontrolled diabetes, we said in patient management, blood sugar of 200, more than 200. If the blood sugar is more than 200 milligram per deciliter, that is uncontrolled. Patient who has AIDS, we said, is different than HIV infection. AIDS means HIV infection with CD4 plus below 200 per microliter. Okay. Advanced stages of leukemia and lymphoma, not all stages, just advanced stages. Usually patients who have advanced stages of leukemia and lymphoma, they are receiving radio or chemotherapy. And that's one of the reasons that they need antibiotic prophylaxis. End-stage renal disease, organ transplants under immunosuppressive medications. Okay? So organ transplant under immunosuppressive medications, which is which may receive chemo or radio or some immunosuppressive medications. You have to know some examples of immunosuppressive medications. You have it in your pharma session, such as tacrolimus, what else? Methotrexate and cyclosporine. Yeah. So, pay attention, organ transplant only as long as they are receiving immunosuppressive medication. And I do not include corticosteroids here. Immunosuppressive medication, not steroids. Steroids can affect the immune system as well, but still, it's not to the level that requires antibiotic prophylaxis. Okay. Let's see. There's also one point about chemo and radio. So for chemo and radio, up to 1 year after cessation of chemo and radio, they still need antibiotic prophylaxis. So it means not only duration, but after up to 1 year after, they need antibiotic prophylaxis. Orthodontic bands requires antibiotic prophylaxis. Yes. Restorative matrix band does not need antibiotic prophylaxis. Yes. The only time that restorative matrix band requires antibiotic prophylaxis is when the question clearly saying that you are doing a subgingival restoration. In that case, yes. But in general, if it says restorative matrix band, no, it doesn't. Only for subgingival restorations. Okay. And we said for the prosthetic joints, we don't need antibiotic prophylaxis. Okay, any question? LA block does not need antibiotic prophylaxis. Root canal treatment does not need antibiotic prophylaxis. Suture removal in uncontrolled condition. What does it mean? What do you mean by suture removal in uncontrolled condition? So when a situation does not need antibiotic prophylaxis, it means if the patient has AIDS, does not need antibiotic prophylaxis. So we said suture removal does not need antibiotic prophylaxis, so it means it doesn't matter what situation that. Does hypertension require antibiotic prophylaxis? No. Okay. So guys, read the options carefully. Not any uncontrolled medication requires antibiotic prophylaxis. All conditions related to chemo and radio require antibiotic prophylaxis up to 1 year after cessation of the medication, okay? Instead of clindamycin is just removed. Forget about clindamycin. What is the drug of choice in patients who are already taking antibiotic? What antibiotic? This is not the right question. What antibiotic? What antibiotic the patient is taking? If the patient is taking tetracycline, I don't give the patient doxycycline, I give the patient amoxicillin. The rule is that you have to change the class. There is no antibiotic of choice in that case. You can give Claritro, Azitro, Doxy. Any of these would be acceptable. There is no first choice. Okay. Good. So moving to the next chapter. This is a short but super important chapter, the antibiotic prophylaxis. Mainly focused on infective endocarditis. That part of the chapter 3 is more important. Okay. So How long before procedure? That's a good question. I missed this part. How long before the procedure should we give antibiotic? 30 to 60 minutes. Okay. So if the patient has forgotten to take the antibiotic prophylaxis, let's say the patient came to your office and you did the surgery, you did the extraction, and the patient said, oh shit, I forgot to take the antibiotic you gave me. What should you do? Did you get the question or no? Patient requires antibiotic for a procedure. Patient forgot to take the antibiotic. You did the procedure and you asked the patient, so you took the antibiotic and you said, oh, I forgot. What should we do? There is no reschedule. You already did the procedure. Reschedule what? Yes, that's the right answer by Rami and Eileen and many others. You give the antibiotic you can still give the antibiotic within 2 hours after procedure. Up to 2 hours after procedure, you can still give the antibiotic. Ideally 30 to 60 minutes, but it's still up to 2 hours later, it works. Okay? Clear? Yeah. So moving to chapter 4, oral and odontogenic infections. Important chapter, okay? So as you guys know, odontogenic infections are considered as polymicrobial situations. So it means there are several groups of bacteria involved in this situation. But the majority of these bacteria, they belong to 3 groups: aerobic gram-positive cocci, anaerobic gram-positive cocci, and anaerobic gram-negative rods. So it means like the majority of bacteria are either gram-positive cocci or gram-negative rods. Most of the gram-negative rods that we have in our oral cavity, they are anaerobic. So in perio, we also discuss about them. The majority of periopathogens, they belong to anaerobic gram-negative rods. While for odontogenic infections that we are talking in general related to pulp and cavities, cocci, gram-positive cocci, they are the majority of them, okay? Obviously, the most common cause is Streptococcus. And we have different types of Streptococcus, Streptococcus mutans, Streptococcus salivarius, Streptococcus oralis, Peptostreptococcus. So there are different types of these Streptococcus that you should be familiar with. But if they ask you, this is the most important one. There is another group of bacteria which are important here. Anybody knows other than Streptococcus? Lactobacillus, no. Bacterius, the Staphylococcus, not in oral cavity. No. Actinomyces. Actinomyces is also important. Okay, so among, for example, gram-negative rods, we have the Provotella. Provotella is more like a gram-negative agent, like bacteria, okay? In general, we have 3 types of infection. So you guys already know that cardinal sign of infection. I don't go to the basics. I focus on the more important things, one of which is the 3 types of infection that we see in oral cavity. So the first one is called inoculation. The second one is cellulitis. And the third one is abscess. Okay, so highlight this table. This is important.